All right, good. Well, everybody's clear, or they're busy eating, which is good. Got to eat.
All right, that was wonderful, Dr. Flynn, thank you. We're now going to move on to our live demonstration. I'd like to introduce my physician assistant who's come with me from my practice, Matthew Pathros, who's going to be helping me tonight. This is Katya. How old are you, Katya? Can I say? Katya's 46, and what we're going to be doing tonight is just a little brief demonstration to show you some fillers and also some toxin. We're going to be using some Radiesse here. And we're going to be using some Xeomin.
Hema, do you always tend to start with the fillers and then end with the toxin? Are you consistent?
Tim, I'm not always consistent, but when I'm thinking about it, I quite often like to do it that way because if I'm injecting into the same area, I don't want to put in the toxin, first of all, and have that volume of fluid potentially distorting the tissue layers.
Okay.
Because I want to be very precise with the planes that I'm placing my filler. How about you, Tim?
Same thing. I'm always fillers first, and then we end with toxin, and then we animate on the way home driving in the car.
So when we look at Katya's face, Matthew, can you pass me the pointer if it's there? Never mind if we don't see it. When we look at Katya's face, what we can see is that she has quite significant mid-face volume loss. And for me, it all really begins with volumizing the mid-face. So I'm going to start with some Radiesse. We've cleaned Katya's face very thoroughly. This is extremely important, and you'll see that I'm going to be cleaning during the procedure. We're all very aware these days of biofilms, and we want to avoid introducing any bacteria. So I can view Katya obliquely and from above and below and discern an area that I can revolumize with my Radiesse. And I'm going to use exactly what I showed to you in the video, which is this microaliquoting technique. This has been mixed, final concentration of 0.3% lidocaine. And I can just move along here and volumize the medial mid-face. And you'll see these are very small microaliquots, and so far I've put in 0.2 of a cc. This is 0.3, and the amazing thing is you can already start to see an improvement. So this is the power of using a filler that has a high G prime that is volume efficient for lifting, because we don't have to use much of a volume in order to get an effect for Katya. Just hold here for a second, please, Katya. I'm going to change this needle.
Now, can the audience, particularly the residents out there, see what we're talking about? Because it's almost like learning to view or whatever. So in the premalar area, you can see that little hollowing or sulcus that's present there. Take a look at some babies. If you see running away, they're like stuffed apples. They're like extremely attractive, big, volumized cheeks. And as we get older, we lose the fat, our skull atrophies, and we get this sinking area. It's not as attractive. Part of youth is to have nice, convex curves. So what Hema's doing is replacing some of that volume loss and restoring that curve. She's now got more of a cheek on that side. She's got a shadow on her untreated side. Can you all see that?
So at this point, what I've put in is just 0.4 of a cc, 0.5 actually, and look at the difference we've got already. The other area that I like to volumize straight off the bat is the piriform region. This is up at the nasolabial angle. I like to come in slightly from the side because we have to be aware that the angular vessels are here. So we're injecting slowly here. I'm looking out for any blanching. I don't use epinephrine with my lidocaine. The reason being that if I see blanching, that's a sign to me that there may be some vascular compromise. And remember, it's not all about cannulating a vessel inadvertently. What we perhaps even need to be even more concerned about is compressing a vessel. This is another advantage of using a high G prime filler, because we only have to inject a relatively small volume, so I feel we're at less risk of actually inadvertently compressing a vessel. What I want you to see now is if we look at Katya after injection of, about half a syringe of the Radiesse. If I turn her face, can you see the difference here with the side that I have restored volume to compared to the other side? Look at the nasolabial fold. Do you see a difference there? We haven't injected anything into the nasolabial fold, but I think you can see on camera that the right nasolabial fold already looks less deep than the left. So this is really our take-home message. Using a high G' filler like the Radiesse, we can reinflate the midface. Faces don't fall, they deflate. We're reinflating the midface, and in doing so, I haven't even injected into the nasolabial fold, and I've already elevated it quite a lot. These days, the nasolabial fold is actually the last area that I proceed to. I'm now going to show you a little bit in the temple. And what I'm tending to do in the temple these days is go quite far back and vector it into the hairline. So I'm injecting here just above the bone, supraperiosteally, to avoid encountering the temporal branch of the facial nerve, which is going to come up over the midpoint of the zygomatic arch. It's going to pass through the temporal fossa and then curve over the brow. The other advantage of going posteriorly like that and angling my needle is I get a very nice lifting effect. So now I've injected into the midface, I've injected a bit into the temple. Let me show you the pre-gel sulcus.
And of course, this is, I mean, it's nice
you
to
have it
see
already,
that she's
isn't it?
got an awful lot of cosmetic effect with relatively little product. So that's kind of an economic advantage for the patients.
So when we mix the Radiesse with lidocaine, what we're going to get is about 1.3 cc's total. And at the moment, I've used 1 cc, so that would not even be 1 syringe. If we look now at Katya's jawline, I'm going to go down again to the periosteal layer, or just above that, supraperiosteally. I insert the needle to make a tunnel deep, and then I pull back and inject as I pull back. This is retrograde tunneling technique. And now I've injected 0.2 of a cc. And again, if I turn Katya, look at the side that I've injected compared to the uninjected side. And hopefully you can discern a little bit of improvement there. That's really sharpened up her jawline. All I need to do now is maybe just inject a little bit above there, subcutaneously, to get a little more lift. And we can work through the face like that. So those are really our key areas with Radiesse. And can I put some into the nasolabial folds? Absolutely. Before I do that, I'm just going to microaliquot a little bit medially for Katya, because laterally, because we mustn't forget that we can also lose volume from the lateral midface. We want to avoid over-volumizing medially and not taking care of the lateral area. So having done that, I'm now going to move on and use a little bit of dilute HA to show you the superficial volumizing technique. Now, we don't have Bellaterra Balance available yet, so what I've done is I've taken a high concentration HA, this is Restylane, and I have diluted it. There's quite a vogue for doing that these days, but I want to point out one thing, which is when we dilute it, and this is diluted about 1 part of lidocaine plus saline to 2 parts of the HA Restylane, we are decreasing the concentration, and decreasing the concentration potentially decreases longevity. So the advantage, ultimately, if we're using a product designed for superficial injection, like Bellaterra Balance, is that that will remain high concentration. We don't need to dilute it, and we're not potentially impacting longevity. And in fact, we know that's the case from the controlled studies comparing Bellaterra Balance with Restylane and Juvederm and seeing comparable longevity and efficacy. I like to use a long needle quite often for superficial volumization. This is a 30-gauge 1-inch needle. It's a sharp needle again. And I just want to show you this tenting. We'll see it again. I'm going to be filling in for Dr. Fitzgerald on tomorrow morning doing another demo. She's unwell and unable to attend, and I'll be doing another demo for the young physicians and residents on Monday. And I will keep showing you the superficial volumization so you get the idea of how acute this angle is to the surface of the skin. And remember, I can only do this with this particular HA because I've diluted it, so that there aren't enough particles to scatter the blue light, which is short wavelength, and cause the Tyndall effect. But Bellaterra Balance has now been approved. It will be available very shortly, and we'll be able to do that without diluting it. So we can raise the corners of the mouth a little bit. Just open your mouth, Katya. Katya shared with me that she doesn't really want to have a lot of lip augmentation, maybe just a little bit of definition of the lip. And what we can do when we're using an HA that is suitable for superficial injection is we can thread it along the vermilion border, just as we used to do with collagen. And in doing so, we can restore the white roll. Again, if we turn Katya's face, just do a little bit more here, and then I'll show you. Look at that little white line there. And you see the other side, it's not as pronounced. Does that show up on the camera? That's just 0.1 of a cc, and we can already get a little bit more definition for her. What are the other areas where we can use an HA and work multiplane? Well, potentially we can do this. Potentially we can do this for the tear trough area, and this is an area where I do like to use a blunt cannula. I'm using here a 27 gauge blunt cannula, and I'm just going to show you basically how we make the entry hole. I'm going to clean off the area first of all. Now, what do we need to be aware of here? The infraorbital foramen, mid-pupillary line, we can feel the little notch at the orbital rim. So I'm going to make my entry point outside of this area. And the entry point is going to be with a 26 gauge needle, and then I'll use a 27 gauge 1.5 inch needle, 38 millimeter, to actually do the injection. This is a blunt cannula that I'm going to be using. Here's my entry point. We want to stretch it out a little bit because we're using a needle which is not a whole lot bigger than the cannula itself. And I like to keep it around in case I need to go back to it.
So the size of that entry point needle was what again, Hema?
Well, I'm staying away from the orbital rim, as I mentioned, because of the infraorbital foramen and the infraorbital neurovascular bundle. Okay. This is our blunt cannula. So it doesn't have an edge to it.
One of the good ways for the residents to get the location of the infraorbital foramen is to draw a line to the mid-pupil area from where the ala meets the cheek, the base of the ala meets the cheek, and draw a diagonal line up to the mid-pupillary line at the infraorbital foramen, at the infraorbital rim, and just below that you'll usually find the infraorbital foramen.
So what I'm doing now is injecting supraperiostally. This is a deep injection point with a blunt cannula. And it's anterograde injection technique. You can see the product flowing ahead of the needle. And you'll see that she has no bruising from this. And we've gotten already a little bit of correction. So I'm going to continue injecting Katya off camera. I think we have time maybe for a final 1 or 2 questions.
Well, a couple have come up on the little pads there, so.
Yeah. All right.
One person wanted to know how much is Xeomin per vial, and there's all kinds of complex buying programs, but basically I just consider it about 20% less than the cost of Botox, and I don't know the relationship with Dysport in terms of that. The question came up, is non-responder status a result of having treatments more frequently than every 90 days? That is theoretically a concern. But in the Dressler paper, when he looked at that, those people who are the cosmetic secondary non-responders, some received touch-ups, some did not. There was no clear discrimination on that in terms of really identifying that. Go ahead.
We're going to be, if you come back for the demonstrations tomorrow morning, we will take a look at Xeomin injection. Basically, the number of units for that is going to be exactly the same as for Botox. So for instance, around the crow's feet area, if I were to be injecting 4 units of Botox at each site, I would simply do 4 units of Xeomin at each injection point. And that's what I'm going to do now. Go ahead and smile. Go ahead and frown.
Listen, thank you so much for a terrific demonstration. I know you're going to keep going there, and there's, of course, never enough time in the day to get everything we want to get in. But we have a very special event that we want to make sure that we include this evening happening now. We as physicians